So you mentioned your documentation and so forth. What are the kind of critical bits that go in there? So when you're sitting down with the patient in the clinic and looking at the pathology, trying to put it all together, you can help tell Mr. and Mrs. volunteer
and I think
what's
this
up.
is really important because when you have a high volume bladder cancer practice, as you know, things start to run together a little bit. It's easy, and, unless you're really on top of it, I think it's easy to produce somewhat generic notes and documentation. And, just for example, on a Tuesday, which is my, all day clinic day, where I'm doing all the office cystos for surveillance and whatnot, I'm usually doing 10, 8 to 10 office cystos a day interspersed between, 40 clinic patients. So you have to find your own, everyone's got their own way of doing it, but you have to find a way to document well. So, I would say location of tumor, where the size of the tumor, I always note, previous treatment, the patient has not had any prior intravesical therapy because, as odd things in the bladder are common after you've had intravesical therapy. So, location of tumor, size of tumor, number of tumors, access to the tumor. Is the tumor in an area that, may be difficult to access? And then, obviously related findings about, how the bladder looks in general, the urethra, all of that stuff. But that is something that I think we talked about, some of these gaps in the community, right? How surgeons document their cystos and their TURBTs is poor. And there's no doubt about it. We all could be better in doing that. It can sometimes make a big clinical impact. If, I get a lot of outside TUR reports that I'm looking at and it says patient had a tumor on the left lateral wall, it was resected, there was no visible tumor left. That's it. And then you get a lot, you get some really good.
Well, then you look in there and it's like nothing ever took place, right? I mean, especially.
And you don't know what happened. You don't know how big was the tumor to start with. Where was it? And then you see 4 or 5, other areas and you're wondering, well, are these new? And, did these just pop up? So the documentation is really important. And so, you have to have kind of a way to look into a bladder in both an office situation and in an OR situation and really try to describe, what you see. I think that one thing that's important too is, we talk a little bit about CIS. Carcinoma in situ is a really this driving space now for a lot of these new therapies and clinical trials. As someone who runs a lot of clinical trials, what's interesting is, the RECIST criteria for solid tumors, right? That's what a lot of clinical trials go by, where you measure tumors on a scan, on a cross-sectional scan, and you say, okay, well, the tumor was 2.5 centimeters 3 months ago, now it's 1.9 centimeters. So that's a partial response, right? Or it's gone, it's a complete response. We don't have that ability cystoscopically. And with these trials, and I'm sure you've heard this point before, these trials are kind of designed not really mirroring what we do in the real world. If someone has a bladder full of CIS and you put BCG in their bladder and their bladders still have maybe a little patch, but most of the CIS is gone, you wouldn't consider that patient a failure, right? You'd actually say, hey, this patient's doing great. But guess what? Most of the trials, that patient gets kicked out as a failure. And so it doesn't really mirror what we're doing in the real world. And now some of these newer trials are using reinduction and they're doing a second course, but some of the older trials did not. And so their numbers, right, their CR numbers are going to be different. And so I always tell people, you can't just look at CR numbers, and compare these trials across board. So that gets to my point of being able to document well. And if you see a patch of CIS, how big is it? How much of the bladder is involved? Because when you follow that patient up, and if you see an area that's still abnormal, well, is it smaller? Because if it's smaller, I would argue you don't need to completely toss that patient or completely move away from that treatment. Obviously, there are other clinical factors that you would have to think about. But, my personal belief is as we get into this world, there's therapies are going to start sequencing together, right? You're not just going to say, okay, well, you still have CIS in your bladder, we're going to take your bladder out. You're going to look to other therapies and look to kind of really do everything you can to keep patients' bladders in their bodies.
Yeah. And, between that and the pathology, which of course we're talk about, anytime I'm seeing a patient with non-muscle invasive bladder cancer, the main question I'm asking myself, am I going to potentially miss an opportunity of a window for cure if I try something intravesical. Now, if that's BCG naive and they've got multifocal, nodular, extensive CIS, 50% of their bladder wall, variant histology, that person's going to get a fairly straightforward recommendation from me, at least as the standard of care is your bladder's got to come out, sir or ma'am, to not have you die of bladder cancer. And one of the things that I think makes me a little bit nervous, especially as we get more tools in our toolkit, is trying to sort out who that patient it is at any given time point. We're making this decision on if it worked perfectly, all right, that's a no-brainer. If it worked 90%, like you're saying, extensive CIS, now you get a small little patch, you're not worried that person's going to med out in the next 3 months. But it's that gray, right, where you're like, this doesn't feel good, it doesn't feel awful, and nothing fits into nice little tidy boxes. You know, the trials that are all CIS only or with or without papillary. Well, how do you factor in if their bladder looked like choose your expletive? You know, that's the real world, right?